So next is the cardiac risk in transplantation. It's a V4, a 55-year-old man with end-stage renal failure due to chronic pyelonephritis is being assessed for renal transplantation. His past medical history includes hypertension. He has tablet-controlled type 2 diabetes mellitus, as well as being an ex-smoker. His blood sugars are well controlled with metformin, and he is currently pre-dialysis with an eGFR of 20. How would you formally assess his cardiac risk for transplantation? So first of all, take a full history and to identify any evidence of symptomatic coronary artery disease, peripheral vascular disease, or cerebrovascular accident. Then conduct a comprehensive cardiovascular examination. He should have routine investigations of ECG, echocardiogram, chest X-ray. Although asymptomatic, type 2 diabetes and his age, he is a high cardiovascular risk candidate and should therefore undergo further intensive tests like either dobutamine stress test on echo, or myocardial perfusion scan. And sometimes cardiopulmonary exercise testing can be done, but it's not recommended for renal transplant at the minute. The echocardiograph shows left ventricular hypertrophy, but otherwise there is good overall systolic function. Ejection fraction is estimated more than 60%. However, abnormalities are demonstrated on the myocardial perfusion scan. How will you proceed? There is no consensus over the management of asymptomatic patients. Referral to a cardiologist for coronary angiography may be considered, although concerns exist at the potential nephrotoxicity of the contrast median referral. There is no evidence that routine revascularization in the majority of the patients is beneficial. Some patients with prognostically important disease, 3-vessel disease, do benefit from revascularization. How would you proceed if this patient has angina on moderate exertion? Symptomatic ischemic heart disease should be referred to cardiologist for coronary angiography. Revascularization should be performed either by stenting or bypass for any significant disease. Following successful treatment, patient can be considered for transplantation. Now, a 25-year-old patient with end-stage renal failure due to IgA nephropathy is being assessed for renal transplantation. Apart from being in hemodialysis, he is in reasonably good health. How would your assessment of his cardiac risk differ from the previous diabetic patient with asymptomatic ischemic heart disease? So this guy is quite young. Assessment of this patient also same history examination, and he is not a high risk candidate for getting ischemic heart disease. He should have ECG, echocardiogram, and he would not give routine dopamine stress echo and myocardial perfusion scan. The high risk group includes age more than 50, diabetic, coronary revascularization 3 years ago, evidence of cerebrovascular or peripheral vascular disease, abnormal ECG, echocardiogram, and smoker. How does renal failure increase the risk of cardiovascular disease? Volume overload due to excess fluid and anemia leads to left ventricular hypertrophy. Thank you.